Hello, everyone. Happy Valentine's Day, and thank you for joining us for today's webinar. My name is Mary Corey, Education Specialist for WorldLink Medical, and I will be moderating today's event. I would like to mention a few quick items before we begin. First of all, please make note of the features available to you within your GoToWebinar internet browser in the lower right-hand corner of your screen. You should see the chat box where you can enter your questions to Dr. Rosier. They will be answered at the end of the presentation as time allows. This web conference is brought to you by WorldLink Medical. We provide evidence-based, CME accredited education in preventive medicine and age management with a focus on bioidentical hormones. If you are needing CME credits or you're interested in bioidentical hormone replacement therapy, check out our courses on the WorldLink Medical website. We have added a new Part 1 course for April 13th through the 15th and August 3rd through the 5th, which is the last Part 1 for 2018. Registration is open and available online. We have also recently added to our membership program effective this month. The annual membership will include the monthly webinars, monthly journal club, and access to the online article research library through EBSCOhost. Don't miss out because starting in March, the webinars and journal club will be for annual members only. We have also requested CME credit for the upcoming March webinar and plan to accredit all of them here on out. We will have our webinar schedule for topics posted soon. We are going to have our Hormones and Beyond course in the beautiful resort in Tucson, Arizona, a 20th year celebration for Neil Rosier and WorldLink Medical. It's an event you don't want to miss. Save the date, October 5th through the 7th. Our speaker today is Dr. Neil Rosier, is a pioneer and recognized leader in bioidentical hormone replacement field, treating more than 3,000 patients almost since its inception in the early 1990s. With over 17 years of experience as an educator and practicing physician and 29 years of emergency medicine experience, he has dedicated his life work to uncovering the medical literature that supports safe and effective protocols for personalized patient care. He lectures worldwide on the benefits of HRT. He is also the author of Natural Hormone Replacement for Men and Women, How to Achieve Healthy Aging. It is my privilege to welcome Dr. Neil Rosier for today's webinar from his hometown in Palm Springs, California. Hello, Neil.
Hi, Mary. Thank you. Hello, everyone. It's sort of a gloomy, semi-overcast day in Palm Springs. I think we're going to be below 80 degrees for the first time in about 3 weeks. We had one day of winter in December. Anyway, the last webinar, I addressed the controversy of high-dose replacement therapy in cardiovascular disease, and that there's no significant data or study to show harm in outcome studies with high-dose administration, and that the Endocrine Society extrapolation of harm with high levels of thyroid are extrapolated from studies that are baseline studies of patients with Graves' disease that show harm, as opposed to patients that don't have Graves' disease but are treated with very high-dose thyroid. In no study did we see any adverse harm. I refer you to the first webinar. This is a continuation of that, and this study addresses similar but different points, primarily on osteoporosis. And this is a study that looked at the treatment of patients with depression and bipolar disorders with high-dose thyroid, looking to see if there was some adverse effect, side effect, problem, complication, or harm in high-dose replacement, because the endocrine societies are not willing to accept that high-dose replacement should be given, because they always quote high levels of thyroid are harmful. And I do agree, high levels of thyroid are harmful. That's with Graves' disease, and we'll get into why Graves' disease is harmful more into this study. High-dose thyroid hormone has been in use since the 1930s for the treatment of affective disorders and depression, primarily by psychiatrists. Despite numerous papers showing benefit of this therapy and the lack of negative trials and its inclusion in multiple treatment guidelines, high-dose thyroid is yet to find widespread use because of the fear and extrapolation that high-dose replacement, or HDT, is the same as Graves' disease or hyperthyroidism or thyroid toxicosis. The major objection to the use of high-dose thyroid is the myth that it causes, of course, cardiovascular disease, which we looked at in part 1 of this webinar series, and osteoporosis, which is what we'll look at in this study. High-dose thyroid does not appear to be a significant risk factor for osteoporosis. While other widely employed psychiatric medications do actually pose a risk, in the studies where they've looked at it, and I've actually reviewed the osteoporosis studies, of which there are numerous ones in part 2, we don't find any significant adverse effect to high-dose replacement, in spite of the fact that everyone says, yes, high levels are associated with, but that's an association, does not prove causation. And what they're doing, again, is extrapolating the harm of Graves' disease to high-dose replacement. There are no negative trials of high-dose replacement for bipolar disorder, and most augmentation trials for affective disorders are favorable. Yet everyone fears it because of the extrapolation of association. The reluctance to use this high-dose replacement, and I don't suggest that the average everyday physician use high-dose replacement in their patients. I'm just bringing up the study to show that our optimization certainly doesn't cause harm if high-dose replacement does not cause harm. The reluctance to use high-dose thyroid may be based on false beliefs equating high-dose thyroid replacement with hyperthyroidism. As we saw in the first article, it's not the same. Same thing in this study. The literature covering high-dose replacement includes caveats on the risk of hyperthyroidism. They're not the same, but everyone extrapolates them to be the same. Any elevation of thyroid laboratory levels is often labeled as hyperthyroidism, without regard to the presence or absence of thyroid toxic symptoms. Let me look at that for a minute. You and I were taught if you suppress the TSH, it's hyperthyroidism. You and I were taught, don't ever do that. It causes atrial fibrillation, osteoporosis, and death. Although there's no studies to show when we suppress it in patients that have thyroid cancer or thyroid nodules that it's harmful. But again, we extrapolate. And we assume that when the TSH is suppressed, it is hyperthyroidism. But by definition, hyperthyroidism is not TSH suppression. Hyperthyroidism is thyroid toxic symptoms. Out of all of us that have prescribed thyroid over the last 20 years and seen a suppressed TSH, we don't see these symptoms of thyroid toxicosis or thyroid toxic symptoms. Yes, somebody may have some sensitivity to it, lower the dose. That's quite simple. That's easy to do. But they're not thyroid toxic, as some people claim. The use of high-dose thyroid for the treatment of bipolar disorder has never been endorsed by endocrinologists and is considered dangerous because of the extrapolation association. Endocrinologists would never use high-dose thyroid. Psychiatrists always use high-dose thyroid. They never see any problems, and they've studied it. But somehow the endocrine societies ignore that because they go back to the, again, high levels are associated with. For example, one expert states the use of thyroxine in euthyroid patients with a psychiatric illness should be regarded as controversial and potentially hazardous, although unfortunately, the person that claims that cannot cite any study that showed harm. Only the baseline levels are associated with harm. Clinically, endocrinologists equate treatment with high-dose thyroid with hyperthyroidism. They are not the same, but I can't change that. I can't change the world, but understand that that's what their thinking is. Deal with it. Move on. Don't argue. Despite the multitude of papers, expert recommendations, and treatment algorithms recommending the use of high-dose thyroid, some still consider its use outside of mainstream medicine. Well, no, I would not suggest that you do that. I would not suggest that any physician, unless you're a psychiatrist, use high-dose thyroid replacement. The point of this article is, even with high-dose replacement, it is not harmful. There appears to be no risk for osteoporosis from high-dose replacement in men and in premenopausal women. The majority of the studies also show no risk of osteoporosis in postmenopausal women. But these findings are not as consistent as those reported for premenopausal women. Let me address that for a second. There was one landmark study published in JAMA years ago in women over age 70 that had thyroid cancer that were treated with high-dose replacement for the thyroid cancer, and they got osteoporosis and lost bone. Was there a control group? No. So postmenopausal women that were treated with thyroid lost bone and got osteoporosis, yes, but so do postmenopausal women not treated with thyroid, and there was no control group to see which group got worse or if there was any equivalence. So, but nevertheless, that study is extrapolated to thyroid causes osteoporosis, which is really a shame. But as I showed in part 2, there's a multitude of studies and meta-analysis showing that even the high-dose replacement, even in premenopausal and postmenopausal women, do not cause osteoporosis. But yet, high levels are associated with it with Graves' disease. In fact, postmenopausal women are at risk for osteoporosis with high-dose thyroid treatment. The risk may be mitigated by ensuring adequate calcium intake. So in one or two of those studies where they did show increased bone loss and osteoporosis, that was completely reversed with calcium administration. Well, that's pretty simple. Yeah, but you shouldn't use it because thyroid causes it, but all the benefits of thyroid will then be lost if you don't use it. We'll look at those towards the latter part of this lecture. Despite the direct evidence present here, the risk for osteoporosis has historically been directly attributed to high levels of circulating thyroid hormone. Still, the association between high circulating thyroid hormone levels and osteoporosis is only a correlation. It's an observation. Why does hyperthyroidism cause osteoporosis, while high-dose replacement therapy with thyroid does not? Let's look at that. Graves' disease, which accounts for 80% of hyperthyroid cases, and with hyperthyroidism you get symptoms of excess thyroid. It's an autoimmune disease caused by TSH receptor antibodies that mimic TSH. It's probably these antibodies that are causing the problem, not the level of thyroid hormone, because when we replace thyroid in very high doses, we don't see that same harm that we see in Graves. The TSH antibodies stimulate TSH receptors, causing high circulating levels of thyroid hormone, which everyone attributes to the harm of thyroid, in the absence of TSH. However, when we treat patients with Graves' disease and we wipe out their thyroid, and we bring their TSH back to the middle of the range, guess what? The disease continues to progress. Well, it's that hyperthyroidism, it's that high level of thyroid in the serum. No, there's no longer high levels of thyroid in the serum because that's been taken away because we've obliterated the thyroid gland. Yet the disease continues to progress. Well, it's due to those high levels. It's not due to the high levels. The high levels are now normal. In fact, they're probably low, but yet the disease progresses. It's these TSH antibodies that are now accepted as the cause of the exophthalmos, the orbitopathy, and Graves' dermopathy, the pretibial mixed edema. It's not the high circulating levels of thyroid hormone because that's been fixed, but yet you'll still see these symptoms of the disease progress. There's growing evidence that osteoporosis is associated with hyperthyroidism, but it's because, and it's mediated by the TSH antibodies, and not because of the thyroid hormone levels. Because in every study when we use high-dose thyroid, we don't see that. But even in these patients that have their thyroid gland obliterated and their thyroid hormone put back into the perfectly normal range, the disease continues to progress, thereby proving, no, it's not a thyroid hormone, it's something else. It's the autoimmune disease. We looked at that in the first webinar. Normal thyroid laboratory values are based on large population studies. Levels are an average of old, sick people. But normal thyroid levels for patients with bipolar disorder have never been established. Well, I will take that a step further and say, why is everyone stuck on normal? What's normal cholesterol? Normal cholesterol is, 250 to 300. That's normal. That's an average of a population. But that's not what's best. When we see these normal levels of thyroid, we think, oh, that's what's best. That's not what's best. That's an average of a population that we measured of old, sick people. But yet, when we see these patients improve on high-dose replacement, We say, oh, it's abnormally high. It's beyond the normal range. Well, maybe patients need that higher level in order to truly feel well. But we're still stuck on that normal. And we don't want to go beyond that normal. Whereas all these studies show it's not until you get super physiologic that you really see the difference. In part one, I addressed that study from the British Medical Journal that showed that most patients do not feel well until their thyroid hormone is at the high level of normal and their TSH is suppressed. And for those patients that still don't feel well, they will only find improvement of the symptoms when the TSH is completely suppressed to zero and their thyroid levels are very superphysiologic. The article goes on to say there's no study that shows harm in doing this. But everyone will come back and say, yes, but high levels are associated with, and they completely do not understand the difference between association does not prove causation. Evidence suggests that patients are closer to a normal physiologic state, meaning they feel and function normally, in the presence of elevated thyroid hormone levels. But everyone gets upset when they see the elevated levels and a suppressed TSH because we think it's going to cause osteoporosis and atrial fib and it's hyperthyroidism. It's not, but everyone still thinks that it does. I cannot convince the world. I can't show them. But what I can do is hopefully make you more comfortable with treating to optimal levels of thyroid, which was the intent of presenting this paper. Conclusion: high-dose thyroid cannot, by the definition put forth by the American Thyroid Association and the American Association of Clinical Endocrinologists, be considered hyperthyroidism, even if the T3 or T4 are elevated in the supraphysiologic range. It cannot be considered thyroid toxic if no symptoms are present. Patients with Graves' disease have thyroid toxic symptoms. Patients with high-dose replacement, unless you have a sensitivity to it, typically do not have symptoms even though their thyroid hormone levels are elevated. And that's where they feel the best, and that's where you'll see improvement in their symptomatology. Ultimately, the decision to employ high-dose replacement hinges on its comparison to the risk and benefits of other medications or the risk of failing to treat patients to euthymia. And that's what we fail to see. There's two camps here. They're the AACE, American Thyroid Association camp, do not treat to supraphysiologic levels. It's harmful. The other camp is patients don't seem to improve, feel better, or function better until the levels are supraphysiologic, which is completely against the guidelines from AACE. But yet, based on the literature and science, that's where patients need to be in order to truly feel well. There's good evidence and literature support for that. This is just another one of those articles that supports why we do what we do. Moving on, this is an interesting commentary. It's not a study. Actually, there's a study based in this commentary. And the gist of this article is to use T3 or not to use T3. The only randomized double-blind trial to compare desiccated thyroid with T4 alone in a crossover study was published last year in 2013. This is an old article. And it showed that about half the patients preferred desiccated thyroid with T3 in comparison with T4 alone. Patients treated with desiccated thyroid had an average weight loss of 3 pounds. Don't use thyroid for weight loss. If it occurs, just deal with it. In terms of satisfaction, 48% of patients expressed preference for the desiccated thyroid over T4 alone. It was interesting to find out that nearly half of the study patients preferred desiccated thyroid extract over T4 alone, and the desiccated thyroid extract caused modest weight loss. Well, I will play devil's advocate and explain that there's a dozen studies, all sponsored by Knoll Pharmaceuticals, maker of Synthroid, that showed that there was no difference between giving T4 and T3, and there was no difference in improvement in symptomatology, weight loss, etc. However, there's significant criticism of those studies because they were pharmaceutical company sponsored by Knoll Pharmaceuticals, and the dose of T3 that they used was so subtherapeutic that it was worthless. Well, of course it didn't work, but when you go back and then look at all the other subsequent studies where they used higher dose of T3, guess what? All the patients improved. So yes, there's studies to show that it doesn't improve, and that's with low dose replacement of T3. And in those studies that showed moderate replacement of T3 all showed benefit. Well, why can't we then just use a higher dose? Well, because they don't need it, is what AACE says. Well, they do need it, but you can see the political and economic bias, which is very unfortunate. No study patient in this group experienced significant adverse effects from desiccated thyroid. The American Thyroid Association guidelines acknowledge Dr. Huang's study on desiccated thyroid, and they've actually removed the recommendation that used to be present in their guidelines. The old guideline said Armour thyroid should not be used. That has been removed because AACE attendees and members have vociferously opposed that, and so they had to change those guidelines in order to accommodate the suggestions from all the audience that find benefit in prescribing desiccated thyroid. So it's been changed. It used to read Armour thyroid should not be used. That's been deleted, but it still states that T4 remains the treatment of choice. What can I say? It is a step in the right direction. So AACE still strongly recommends levothyroxine over the use of desiccated thyroid extracts in the routine care of primary hypothyroidism. The same applies to the risk for thyroid toxicosis, says Dr. Pepper, who was the author of this study. Regarding the theory that it could cause thyroid toxicosis or be dangerous, where are the case reports of people getting sick on it? There aren't any. Even with extreme high dose replacement, doses I would never think of using, that's cited in the psychiatric literature, there's no case reports of people getting ill from it. All the case reports are baseline high levels are associated with. You will not find a single scientific paper stating any real danger from desiccated thyroid, even though, according to Merck Medco and other insurance companies, based on the Beers criteria, you shouldn't give it to older people. That's based on the Beers criteria. What's the Beers criteria? I think they got together and drank a bunch of beer and said, okay, AACE is going to sponsor this, that you say don't use desiccated thyroid. That's the Beers criteria. But we don't see it in any paper, even though they say it could be harmful, but could be means can also could not be, which is really a shame. So you will not find a single scientific paper stating any real harm from desiccated thyroid. As far as I'm concerned, the medical societies are scaring people away from this. Yes, there's a very significant political and economic agenda to this, which is absolutely disgusting. Next webinar, I will review medical board issues. I will review the politics and economics behind the current guidelines, why it won't be changed, but yet the consideration should be use the guidelines as guidelines, but not as law. Dr. Pepper says, I've had patients who are 60 and 70 years old who are taking this medication. I can't tell you. They are absolutely delighted with it. As I experience it, and all of you that have been doing this for many years will say the same. People don't say, Ben, I felt so much better on that T4. I felt worse when I took the desiccated thyroid. Well, you will if you don't take enough of it. But if you take enough of it, as per the studies in the literature, it results in significant improvement of symptomatology, which is unfortunately rejected by American Thyroid Association due to bias and politics. I agree that some patients are very vocal about this, and I can only sympathize with them. Boy, you should go online and see the posts. They are symptomatic on T4, sometimes depressed, and they're actively seeking a way to improve their quality of life. And by taking an adequate amount of T3, it improves. It does in the studies, it does anecdotally, it does in our practice. But there's still a vociferous push by the thyroid associations against it. Physicians, professional societies, and the pharmaceutical companies should listen and help in this regard. But unfortunately, because of politics and economics, they don't, which is really a shame. Another study, T3 or not, what's the story in combination therapy? This is similar to Dr. Pepper's study and comments, but by a different group. They state, I think that the American Thyroid Association guideline recommendations regarding combination therapy is appropriately cautious, meaning they recommend T4 alone and not recommend desiccated thyroid. But because the data from studies ostensibly showing no benefit of combination therapy may be viewed as flawed. Yes, those dozen studies are all flawed studies, and it's in the literature that all those studies are flawed. They're pharmaceuticals sponsored studies, and they were designed to be failures from the get-go because they only used 5 micrograms of T3, which is a half a grain of thyroid in these studies. But in these studies where they used 20 to 30 micrograms of T3, guess what? They all got better. I personally consider the ETA guidelines on this particular issue to be both reasonable and patient-centered. In other words, what we should do now, at least according to recent medical literature, is to discuss therapies, risk benefits with the patients and let the patient make a decision in their therapy, as opposed to strictly listening to medical guidelines, which is very unfortunate. So now the feeling is, well, if the patient feels better on it, use it. If they're not feeling as well on T4, try the Desiccated. And guess what? They suddenly feel better. While the debate among clinicians continues over combined therapy, and it only continues because of politics and economics against it, online posting and blogs from patients and patient advocates show a continued interest in the treatment with desiccated thyroid extracts and optimizing the therapy. Despite their being generally considered obsolete since the introduction of synthetic formulations during the early 1960s. It's obsolete because of drug company marketing and drug company profits. But if the studies show benefit, then why can't we use it? Why shouldn't we use it? Why should they continue to get away with saying we don't recommend it? Why should they continue to get away saying T4 still remains the treatment of choice when all the studies show benefit if you use a high enough dose of T3? Among the first-line treatment for hypothyroidism, the treatment still represents for some the ideal combination therapy. The gland produces T4 and T3. When you take T4, you'll shut off the gland's production of T3. If you take purely T3, you'll shut off the gland's production of T4. So an ideal combination would be T4 and T3 to make up for what you're shutting down when you give thyroid. But the reason you're shutting it down is because it's not producing an optimal amount as it is, and the patients then become symptomatic. I suggest Armour to patients because it's economical and it's simple, says Gary Pepper. Well, here's the bad news. Armour is no longer economical and simple. Armour is very readily available. There is no shortage of Armour. The problem is that it's expensive. Insurance companies won't pay for it anymore because the price quintupled. And the reason the price of Armour quintupled is because a subsidiary of Knoll Pharmaceuticals, Allergan, bought Armour Thyroid, and the price quintupled. Now insurances won't pay for it anymore. Patients won't pay for it either because it's 5 times the price. So long, Armour Thyroid. Unfortunately, then there was a mad dash and scramble for Westhroid and NatureThroid. Well, the mad dash and scramble resulted in hoarding, and of course, they've fallen behind in their production, and they can't access it or get enough of it either. In October, I was told November. In November, I was told, no, they'll have it in December. In December, I was told, no, they'll have it in January. And now it's February, and it's still not available, at least to my knowledge. So there is one thyroid that is available, and that is NP thyroid that can be ordered, but unfortunately, there's a rush on that also, and it can be difficult to get also. However, compounding pharmacies still have it available. The compounding pharmacy that sponsored this talk has very adequate supplies of desiccated for compounded thyroid, as well as NatureThroid, Westhroid, and NP. So it is still available, but probably will not be available through your regular pharmacy and won't be available through other compounding pharmacies because there is a shortage of it. I will caution everyone that the majority of the cases, unfortunately, of medical board complaints that I see do not come from physicians or patients. Patients never complain about their thyroid. They're perfectly happy and content with it. I've never seen or heard of a patient complaining about thyroid administration that's desiccated. Occasionally, some physicians have issues with it, but the main issue problem that I see in patients and doctors having to defend themselves before the medical boards are complaints from pharmacists. I put pharmacists now in the same bag as rattlesnakes and attorneys. So I cannot caution you enough to make sure that you use a compounding pharmacy that is well-versed and understands therapy. And for those physicians that I've had to defend, they will always come back and say, but I didn't think it was going to happen to me. No, I trusted this pharmacy. I thought the pharmacist understood what I was doing. It was a good compounding pharmacy. The rattlesnake was really cute. I couldn't understand why it bit me. I cannot emphasize this enough. I'm trying to explain the rationale for using thyroid, the benefits of it based on the medical literature, but you need to understand the resistance for political and economic reasons that are against it, the studies that have shown that it doesn't work that are flawed, but there's this also tremendous denigration of desiccated thyroid, and even the pharmacists play into this role, that they don't think that you should be prescribing it, period, or they don't like the dosing that you're using. So enough of the cautionary comments, but that's what I'm trying to do, is to help practitioners weed their way through this. Moving on. One problem with combination therapy, and that's synthetic T4 and synthetic T3 or Cytomel, is that people find it very difficult to take 3 pills a day. And with Cytomel, with the half-life being around 4 to 6 hours, you have to dose the T3 3 times a day, and it's real expensive. Cytomel is very expensive, and the desiccated thyroid is so much cheaper and easier, and as Dr. Pepper says, people won't take it 3 times a day. With Armour Thyroid, you only have to take it once a day because it has a prolonged half-life of T3. Furthermore, the synthetic T3 is very expensive, so I'm really looking at it from a more practical point of view. Now, Armour Thyroid is also very expensive, and it's interesting. If you can't beat them, join them, and that's what Knoll Pharmaceuticals did. They bought the manufacturing plant and bought Armour Thyroid, and they pretty much have tried to suppress the industry. But we will prevail, and there's other options that are certainly available, but perhaps maybe not covered by insurance. In a study he published this year, Dr. Pepper described satisfaction ratings among 154 of his own patients who were still symptomatic while on T4 alone and were switched to Armour Thyroid and saw benefit. This was published in 2014. After a minimum of 4 weeks on Armour, 78% expressed a preference for Armour compared with T4 alone. There's no serious adverse effects noted, in spite of the fact that the Beers criteria state it could be harmful, it could be potentially. That's an extreme bias that we don't see in any study. There's no serious adverse events noted in this study or in any other study with desiccated thyroid, even in patients that were 65 years of age or older. In spite of the fact it's denigrated, we don't see any harm in any study, and you have to understand the denigration is due to politics, economics, agendas, and a confirmation bias against it. You and I were probably taught, don't use desiccated thyroid. I was taught that 30 years ago. It doesn't work, it's trash, it's junk, don't use it. Yeah, but all the studies show that it benefits patients, and anecdotally, all of our patients do much better on it. Then why can't we use it? Because they don't need it. They shouldn't. There's no greater extreme bias in medicine than when it comes to thyroid. Moving on. This is a psychiatric journal, the Journal of Affective Disorders, looking at the use of T3 and long-term augmentation of T3 with depression. The addition of T3 is one of the most widely studied augmentation strategies for the treatment of refractory depression. In fact, for those of us that have used this significantly, and as I showed in part 1, testosterone helps improve depression, estrogen improves depression, DHEA improves depression, progesterone improves depression, and so does thyroid. All hormones have been shown in the medical literature to improve depression. But in this study, it was long-term and high-dose augmentation with T3 was utilized for major depression. 14 of 17 patients showed improvement. The average dose was 80 micrograms, with the range being 25 to 150 micrograms. 150 micrograms of T3? Desiccated thyroid contains 9 micrograms per grain, and they're using 150? Holy smokes, that's a humongous dose. Any adverse side effect? Problems, complications? No. Only that they felt better. The average length of time on T3 was 2 years. While the dose of T3 has been limited, the dose of T4 in past studies has been reported as high as 600 micrograms. That's 0.6 milligrams. Whoa, that's like a whole bottle of thyroid. That's extremely high, but that's what was recommended for routine use. Wow, why would they use such a high dose? Isn't that harmful? Not according to the studies, but they all felt better. The depression resolved. Studies of high-dose T4 indicate the safety and tolerability of supraphysiologic doses of thyroid hormone. However, high levels are associated with harm, but high-dose administration is not. In this study here, dosing started at 25 micrograms of T3. It was adjusted every 2 to 3 weeks in 12.5 microgram increments, which is what I've taught you to do in part 2, increased to therapeutic effect. And it was increased as clinically indicated until remission was achieved. What a concept. You treat until the patient feels better. Yeah, but they weren't hypothyroid. Yeah, but their TSH was normal. Yeah, but perhaps the receptor sites are resistant and require a higher dose of thyroid to improve symptomatology. All the studies show that. But yet AACE guidelines state, no, you shouldn't use thyroid if the TSH is normal. Unfortunately, the psychiatric literature and psychiatrists ignore that. They treat the patient, not the number. No females in this study had to stop because of failure to respond or side effects. No patient developed osteoporosis, osteopenia, or atrial fibrillation, or any other major adverse event. Superb study showing it's not harmful, it's safe, but yet everyone will say, yes, but this study showed. We'll get into that next webinar. And I will go through all the negative studies. I will go through these studies and explain the flaws in the study, the flaw in the design and the flaw in the interpretation, and the flaw in their extrapolation. But unfortunately, it's interesting that the experts that write these papers don't understand that. It's so very fascinating to look through this. Now you understand my passion. This study corroborates the strong results seen in other studies that use a fixed dose of 100 micrograms of T3. Big dose. All females responded. It's usually females that tend to be thyroid resistant. This supports the findings of others and a meta-analysis that women are more likely than men to benefit from the addition of T3. I find that in my experience too. Women typically will feel much better on T3. Men do not. On the other hand, I would love to show you all those studies. Ken Wilgers from Beaumont, Texas, showed me all these labs recently where his cholesterol levels in these men go from 300 to 170 on the therapy, and no other therapy. He doesn't use cholesterol-lowering medicines. He just uses hormones. And we all see such tremendous benefit when you optimize, but the optimization is what bothers people, and that's what scares people, and that's what people don't quite understand. I've addressed this ad nauseum in the courses. I won't spend the time here. In the majority of patients, 71%, the initial positive response was subsequently lost. So you see an initial blast as we see these patients, but over time you see that change. This may represent the downregulation of the thyroid gland's output of endogenous T3. That's what happens when you take T4, you suppress T3. But you can also take T3 and suppress the production of T3 also. Well, you may need to add a little bit more T3. That's why they adjusted it based on symptomatology. And that's what I have to frequently do, is adjust the dose based on symptoms and not on numbers. If you're going to measure numbers, you'll get scared. If you're going to measure numbers, then you'll have to reduce the therapy based on those numbers. Then refer the patient to me and let me fix them, if you get my drift. Another study, getting away from the psychiatric literature, is the low T3 syndrome, which I've addressed in the courses, but this is sort of a different take on it. Clinical and experimental data have suggested a potential negative impact of low T3 state on the prognosis of cardiac disease. I showed in part 1 that the American Thyroid Association completely rejects the low free teeth syndrome. They completely reject low-free T3 being harmful or having abnormal prognosis with low-free T3. They completely reject all the studies showing benefit of adding T3 to cardiac patients. But again, it has to do with politics and economics at its finest. They will completely reject it even though the studies show benefit. The aim of the present prospective study was to assess the role of thyroid hormones in the prognosis of the patient population with heart disease. They already have heart disease. What can we do to make them better? Well, the rest of the world gives them statins, and that's it, period. But as we saw in the recent Part 5, the absolute benefit is less than 1%. Results in this study, free T3 was the highest independent predictor of death. What is it that we don't understand about this study? Well, it's from a cheap, worthless journal like Circulation. No, it's probably the most peer-reviewed cardiovascular journal. And it's in the journal, but yet cardiologists completely resist it, reject it, don't understand it. It's beyond their comprehension. It's beyond their capability. It's beyond their scope of practice. Yes, but everyone with low free T3 has an increased risk of death. Don't you think you'd want to address it and improve it? Well, no, it's beyond the scope of practice. The TSH was normal. We didn't give him thyroid because the test was normal, but the free T3 that's predicted, the highest independent predictor of death, was low. What is it that you don't understand that? Well, the TSH was normal. No, you didn't answer my question. What is it that you do not understand about the study? What is it you don't understand about the data that's showing that it's T3 at the cell level, not T4? And the lower the free T3, the greater your risk of dying. What is it you don't understand about that? Well, the TSH was normal. They just don't get it. Low T3 syndrome is a strong predictor of death in cardiac patients. It might be directly implicated in the poor prognosis of cardiac patients. Every cardiac patient should have optimal T3. Every patient in my practice for the last 20 years, I've optimized T3, and not only optimized it, yes, it's in a supraphysiologic range. Oh, you're going to get atrial fibrillation. No. The cholesterol level fell 100 points. The cardiac output improved. The systemic vascular resistance decreased because of the unloading of T3. All the patients felt and functioned much better. There was no harm in any study and in any of my patients. But yet there's still resistance against it because they just don't get it. Clinical and experimental evidence has shown that T3 plays a major role in modulating heart rate and cardiac contractility, its cardiac output, in increase in ejection fraction, as well as peripheral arterial resistance. It lowers systemic vascular resistance and increases ejection percent. I showed that study in Part 2 in the cardiac section, where giving T3 dramatically increases cardiac output. I was able to finally convince my cardiologist and one cardiac surgeon at my hospital to use T3 post-operative. Then P&T committee came along and said, T3 IV is too expensive. We're going to take it off the formulary. And that went bye-bye. It was really unfortunate. In spite of the fact that the data and the studies that I gave to them showed improvement, now they don't use it. Well, they could use desiccated thyroid, not on formulary. They need an endocrine consult first. Oh boy, here we go. T3 actions are carried out by binding with specific nuclear receptors that regulate responsive genes, encoding for structural and functional cardiac proteins. Direct extranuclear non-transcriptional effects have also been described. It's the signal transduction inside the cell of T3 that results in improvement, not T4. It's strictly T3. Oh, if you give enough T4, it automatically converts into T3. If the body needs it, it'll make it. Wrong. Incorrect. The principal pathophysiologic mechanism underlying low circulating T3 is the reduced enzyme activity of the 5' deiodinase enzyme. It's responsible for converting T4 into T3 in the peripheral tissues. This low T3 syndrome has commonly been interpreted by the medical community as the euthyroid 6 syndrome, which is also completely rejected by the American Thyroid Association. And it's felt to be an adaptive compensatory mechanism, and thus beneficial response that decreases energy consumption in disease states, but unfortunately increases morbidity and mortality. This interpretation, however, has recently been questioned. No studies have focused on documenting a direct link between low T3 and poor prognosis in cardiac patients, which is what the study did. Low T3 concentrations, pathophysiologic role is not well understood. Well, it's at the cell level that T3 is responsible. Pretty obvious to me. Although the common belief is in favor of an adaptive mechanism to preserve energy, and that's why the body shuts down conversion of T4 into T3 and conversion of T4 into reverse T3. Nonetheless, based on the knowledge of the fundamental actions of T3 on both the heart and blood vessels, a direct relationship between low circulating levels of T3 and adverse prognosis of cardiac patients has been representative in an attractive hypothesis in the last few years. There's a multitude of studies that support this. This is just one of them. The present study clearly shows the existence of a strong association. Yes, it's an association between the reduction of biologically active T3 and mortality in large population and cardiac hospitalized patients. The Kaplan-Meier curve shows the highly significant increase in the incidence of cardiac and cumulative deaths in patients with low T3 in comparison with normal T3. Where would you like your levels to be? Where would you like the levels of your patients to be? The relevance of the low T3 state as a strong independent predictor of mortality in cardiac patients is even more emphasized by our results, which unfortunately are completely ignored by most cardiologists, and of course completely ignored by the endocrine societies. As a side note, we've had several endocrinologists attend the recent WorldLink courses. Thank you, Dr. Kandambi, for referring some of your endocrinology buddies. In conclusion, low T3 concentrations are a strong independent predictive marker of poor prognosis in cardiac patients and might represent a determinant factor directly implicated in the evolution and prognosis of these patients. Well, what's so obvious then is, well, then why don't we optimize with T3? That's the million-dollar question. Because of politics and economics, that's why we don't. Lastly, thyroid hormones affect recovery from depression during antidepressant treatment. There's a multitude of these studies. This is just another one that I came across. Total T3 levels were associated with better cognitive functioning. Really? I showed that one study that was published, this was in part one, published in a geriatric journal, that showed that euthyroid individuals that were treated with thyroid had improvement in memory and cognitive function. Yeah, but the thyroid levels were normal. Why did you treat them when the levels were normal? Because they were not optimal. The conclusion of the study was thyroid hormone levels in the upper range of normal or supraphysiologic are required for optimal brain function. Yeah, but it's going to cause osteoporosis and atrial fibrillation. Isn't it amazing that we don't get it? And it's fascinating that the brilliant researchers in this field don't get it. Total T3 levels associated with better cognitive functioning. What's the conclusion from that? Well, the higher the level of T3, the better. Our study suggests that thyroid hormones may have an impact on severity and efficacy of antidepressant treatment. Yes, it helps improve depression, but it also helps improve memory and cognition. Aricept, Namenda, don't work. Studies show they don't work. Clinically, they don't work. None of my patients have seen it work. None of the families noticed any improvement. But when I put grandma and grandpa on optimal thyroid replacement, it's night and day difference. Patients will come back to me and say, why did it take so long? How come you understood this? How come you knew this and nobody else did? And when I went back to my doctor, they said, no, get off the thyroid. You don't need it. But when they get off of it, then the symptoms come back. I know all I can do is try to explain to patients that their physicians do not know or understand or comprehend the difference between normal and optimal. Well, I hope that I have explained the difference between hyperthyroidism, Graves' disease, thyroid toxicosis, and high dose replacement. and that there's no equivalency to those terms. I hope I've given you some confidence in optimizing thyroid and showing you that high dose replacement does not cause any harm. In fact, shows benefit. And I've shown that optimizing T3 helps improve cardiac patients, helps improve depression, helps improve memory and cognition. And low levels, maintaining low levels, are associated with harm. Thyroid is no different than any other hormone. Optimizing it tends to help improve well-being, function, quality of life, health and wellness, morbidity, and mortality, just like all the other hormones. I hope that was fun. Let's go to some questions. Cindy Cohen asked, do you use reverse T3 to add cytomel to synthetic T4 or to optimize armor? I do not. What does a low reverse T3 indicate? Well, it indicates that you're not converting. And as I explained, that's the low T3 syndrome. And what's that due to? Age, genetics, I don't know, a multitude of different things. And that's just the way that it is. Christine Boss says, hi, Neil. Hi, Christine. Audio cut out multiple times. Could you please, I'm sorry, comment on the relationship of reverse T3 in regards to its significance when dosing T4 and T3. Every time I go through this and explain it, someone comes back and says, but this study, but that lecture, then knock yourselves out and test the reverse T3. But I challenge you, is the reverse T3 that important to you that you would pay for it yourself? What if you had to pay for that reverse T3 on all these patients? Would it really make that much difference? Will it be of that much importance for you to measure reverse T3? Probably not. So I used to say, don't measure T3, reverse T3, and everyone would come back and complain and say, well, no, you're wrong. Knock yourselves out. Go ahead and test for the reverse T3, but don't ask me how to interpret it. Don't ask me what the significance of it is, and don't ask me how it helps me manage patients. It doesn't. I optimize free T3, and I treat to symptomatic improvement. A reverse T3 does not help me in any of those aspects. Chris Newman asked, have you ever had a patient treated with high-dose thyroid develop Graves' or Hashimoto's, and what was the approach? Yes, 5 to 10% of the population will develop Graves' disease. So if you treat enough patients with desiccated thyroid, you're going to see some of those patients develop Graves' disease. It's not because of the Graves' disease. Excuse me, it's not because of the thyroid replacement. It's an autoimmune disease. Giving thyroid does not cause an autoimmune disorder. But yes, they will develop Graves, and they'll have symptoms of excess thyroid. So that's why I monitor TSH, T4, T3 levels on a yearly basis, because Graves' disease is sort of a slow process, and you can start to see changes in, significant TSH suppression or changes in, T4 production, even though most of the time the T4 is suppressed when we give desiccated thyroid. When you start to see levels of T4 go up, and they're no longer being suppressed, it's because you have a thyroid gland that's not sensitive to suppression anymore. So it's being stimulated by the TSH antibodies, and you're going to make a diagnosis of early Graves' disease. So yes, you do see it, but treating with thyroid has no effect on it whatsoever. What's my approach? You treat it just like you would any other Graves' disease. Hi, Loki. I hope you got my last email. Asked, what sort of change do you see in hemoglobin A1C with T3 optimization? I sort of thought that you'd be able to answer that yourself. I see significant changes in hemoglobin A1C, but the only way you're going to see changes in hemoglobin A1C are if you reduce the visceral fat. There's diabetic medicines that will help lower hemoglobin A1C and give you better control of diabetes. I won't get into that. But what else can you do then to lower hemoglobin A1C? Well, hormones do not have any direct effect on lowering blood sugar per se, as do diabetic medications, but they have a significant effect in lowering visceral fat, which in turn reduces hemoglobin A1C and lipids and hyperlipidemia, inflammatory markers, etc. So I see significant change, and as I've explained in the courses, for those patients with metabolic syndrome or metabolic disorders, I will tend to use higher dose replacement in order to get them optimized. And when you do that, you'll see the same thing that Dr. Wilgers saw in his patients that have dyslipidemia. You'll see a decrease in cholesterol and an increase in HDL. There's no drug that raises HDL. Niacin does a little bit. The only way to get the HDL up is to reduce the visceral fat. But no one quite understands that. No one comprehends that. So we can get the cholesterol from 300 down to 170, but your HDL is still 30, and that's not what's doing you any good. The triglycerides are still high. That's not doing you any good either. You got to get the visceral fat down, and you have to improve metabolism, and that's what you do with all the hormones. Dr. Truck says, great lecture as always. Thank you for thanking. Cindy Cohen asks, do you have studies that show the efficacy of high dose replacement in patients with bipolar disorder? Yes, that's what I just reviewed. Michelle Reyes asks, how do you manage the psych patients that need high dose T3 that eventually quit responding? Well, the first thing is they need to be treated and seen by a psychiatrist. I would not use high dose T3 unless you're a psychiatrist. And if you do not know of anyone, you can contact Russ or Dana, and they will go through a list of psychiatrists you can refer to that are comfortable with using very high dose T3 and understand the science and literature behind it. So how I manage those patients is refer them to a psychiatrist that knows what they're doing. I don't personally manage those patients because I would be criticized for using high dose thyroid to treat depression or bipolar disorder if they're not already being seen by a psychiatrist. Is there any way to treat the thyroid antibodies? Well, that's an autoimmune disease, and no, I don't know. I haven't seen any. With Hashimoto's, people say, well, avoid gluten. I chased anti-peroxidase and anti-thyroglobulin antibodies for 10 years. I chased it with gluten-free diets and low-sugar diets, and it porpoised. It went up and down, went up and down. I was not able to change the antibodies, and it doesn't change my therapy. My therapy is still going to be thyroid hormone. So I don't chase the antibodies. You can chase the reverse T3. You can chase all the antibodies that you want. And once you spend enough money on it and realize it really doesn't help me optimize, then it doesn't. I don't use it. But you can, absolutely. Gina says you have Hashimoto's and currently have a normal T4 and free T3 of 1.6. Is that an error? A free T3 of 1.6, which have a normal TSH? TPO antibodies are elevated. Advice, please. Well, you need more thyroid, and it will be a long dissertation to explain the reasoning of the many different reasons why your free T3 is still too low. But make sure that you're taking a very good amount of thyroid from a very good source. I can't explain it any better. And obviously, when you test it, make sure that you test it at the right time. Warren asked if T3 is T3 having the greatest activity? Yes. Why bother with T4? Well, you need T4 and you need T3, so I measure and monitor both. I prescribe both T4 and T3 together. If you give just T3, you'll suppress the TSH, and you'll suppress complete production of T4 by the gland. When you give T4, you shut off production of T3 by the gland. If you give just T3, you shut off T4 production by the gland. You need T4 to get into the brain, and you need T4 also when your T3 is starting to wear off, because the half-life orally is only going to be around 8 hours. If T3 is not getting absorbed into the CNS, it does get absorbed into the CNS, but not as well as T4. But it truly does still get into the CNS because we see improvement in patients by giving them, as you see, this high-dose replacement and giving them just pure T3. But it could have an adverse effect on T4, but it is true. It's T3 at the cell level that's responsible for improvement, not T4. What is the mechanism by which it's helping depression? I don't know what the mechanism is, sorry. I can't tell you. Dr. Motamedi says, you have a 67-year-old female, feels great on Armour Thyroid, 180 milligrams. Appreciate my sarcasm. Man, that's a high dose. What are you doing treating with such a high dose thyroid? I know, trying to make them feel and function better and make them live longer. So anyway, we have an optimal level of T3. It's been getting a letter from her insurance that desiccated thyroid over age 65 is not safe. You're absolutely right. You will get those letters, and they want me to adjust the dose. Really what they want you to do is to stop giving desiccated thyroid. So this is what happened. Knoll Pharmaceuticals went to the insurance companies and said, look, we'll cut you a deal. We'll give you a discount on Synthroid if you send out a letter to everyone saying that desiccated thyroid is harmful. And you'll save millions of dollars. And the insurance company says, you mean all we got to do is send this letter out? Yep. And we're going to save millions of dollars? Yep. Letter is sent. Great. I think that most physicians understand it's nonsense, and probably most patients do also, but they're of concern. And I basically explain to the patient, it's politics and economics at its finest. It's not harmful. Show them the studies from Dr. Pepper. Show them those articles that I just went through. I give you those so you can show patients, yeah, there's a significant economic and political bias against it. And that's the only way I can say it. It's very, very safe. And look at Dr. Pepper's comments. And there's no study to show harm. So anyway, she feels tired again when you dropped her dose. I have a solution for that. What would I do in this case? I would refer that patient to me. Let me fix her. You get my drift. Hi, Heshi. Dr. Klein says, are you changing the standard ratio of 9 to 28 when you're optimizing T3? No, I'm not. If so, how much and quickly can you do that? I adjust it monthly. What's your definition of optimized? Definition of optimized is clinical euthymia, where they have no symptoms of low thyroid. You said last time that you have fibromyalgia patients on as much free T3 levels of 5, 6, or 7. Yes, sometimes you're going to have to get levels up to optimal in order to treat their fibromyalgia pain and their symptomatology. Dr. Hartig asked, if I optimize thyroid and for some reason the patient wants to stop therapy, how long will it take for the thyroid to produce the previous baseline levels? About 1 week. Your free T3 level has a half-life of about 8 hours. It will fall and back to baseline. However, your T4 has a half-life of about 2 to 3 weeks. So it will take at least a week or two before your levels will completely fall back down to baseline. And, you know, there's millions of people out there on suppressive doses of thyroid, and when they stop the thyroid and run out, the levels go back to baseline, just as it was before. They don't completely stop suppression. It will go back to baseline, but probably within a week to two, certainly within 3 weeks. Dr. Reyes asked, when the bipolar depressed patients are managed by initial optimization with desiccated thyroid, and then adding T3 as necessary, is this a problem with loss of efficacy? No, you can do that. I typically optimize with desiccated first, and then if needed, then I will add T3 separately. Dr. Newman asks, is there a role in iodine supplementation when optimizing with T4 and T3? If I said no, everyone wants to jump down my throat because they say, no, that's wrong. So I will say, yes, absolutely. You can use iodine with thyroid optimization. In the question, it says T3 and T4. What does the 3 and the 4 mean? Well, T4 is 4 iodines and T3 is 3 iodines. So when you're giving thyroid hormone, what are you giving? You're giving iodine. So my supplementation is with thyroid hormone. It's all iodine. I don't necessarily need to give more iodine in addition to the iodine that I'm already giving in the thyroid compound. But if you want to add extra iodine, yes. Iodine is contained in the vitamins that I prescribe, in addition to the thyroid, and I prescribe thyroid to everyone. However, if you were not taking thyroid and you wanted to take iodine, yes. It's shown in the goiter belts when people did not have iodine in their food that they got goiters because of loss of iodine and iodine deficiency. But so far, we haven't really seen any iodine deficiency here in the U.S. now that we have iodine in the food. But iodine's in the vitamins, and I recommend that. And iodine is certainly in thyroid. You get plenty of it. But for those that still say, nope, you're wrong, you still got to add it. Yes, absolutely. Add the iodine supplementation onto what you're giving as thyroid. But iodine does not convert T4 into T3. It's taken off an iodine. And that's what the problem is. And iodine does not help receptor site sensitivity and signal transduction inside the cell. It's the T3 in the cell level that's responsible for symptomatic improvement, not the iodine. Hi, Jorge. Thank you for the thanks. Can thyroid replacement have a role in elderly people with dementia who are euthyroid? Oh, Jorge, how can you ask that? Oh, I thought you'd know that. Remember part one, all that nice studies showed that older people that got thyroid, and this is in patients that were euthyroid that had normal thyroid levels, it improved. And the study that I just showed here, there's 1 or 2 studies showing that thyroid hormone helps improve cognition. I think it was the second to the last study. So yeah, there's lots of studies out there, and I'm sure that you will see that clinically. I know a neurologist, Dr. Pelez is a neurologist, used Aricept and Namenda. I used it for years because patients' families requested that I use it because they read about it. I never saw improvement in patients, but I certainly see improvement clinically, and I see it in the literature with optimizing their hormones, and thyroid is just one of those. So yeah, please, Jorge, optimize all of your patients. Oh, you are listening, Ken. Some of the peptide proponents are now talking about using subcutaneous TRH daily for multiple benefits. If you've seen any studies on this approach for optimizing thyroid, no, I've not seen any studies. I can't imagine what subcutaneous TRH costs. Here, Mrs. Smith, you can shoot yourself with a needle once a day, or you can just take this little pill. Which would you like? Oh, and by the way, the shot probably cost, $10 a piece, and the thyroid cost maybe 20 cents. Your choice. No, taking thyroid is so incredibly simple and cheap that I don't think that there's any other solution. Just optimize it with desiccated thyroid or NT3. Problem solved. I don't do all these tests. I don't test for reverse T3. I don't chase antibodies. I don't do all those things. You can chase them all you want. If you come up with something, let me know, because I've asked attendees for 20 years, let me know when you come up with something, and no one has let me know yet, other than, well, somebody else says. Kimberly asks, what's the highest dose you would treat T3 with Armour before referring to a psych? I would treat whatever dose optimizes their symptoms, and if they still have issues, then I would refer that patient to a psychiatrist. There's no specific number. Dr. Matamati asks, besides the cost, any preference between Armour and compounded desiccated? Yes, absolutely. Armour is priced out of reach. Compounded desiccated is still available through compounding pharmacies and is so much cheaper. I do not know why anyone would prescribe Armour, because insurance doesn't pay for it, and the cost is 5 times as much as compounded. So it makes no sense to use Armour anymore. Sorry, it's a dead horse. Until I become Surgeon General, the price of Armour Thyroid will be astronomical, and it'll pretty much go by the wayside, which is what Knoll Pharmaceuticals wanted to happen in the first place. Michelle asks, is there any evidence that there's a receptor resistance to high-dose T3? Yes, and the evidence is based on symptoms. Based on studies to show, like that one study I showed, the initial improvement that they saw was eventually lost, which then required a higher dose. There's various thoughts as to why that happens. but yeah, there's could be thyroid resistance, which would require a higher dose. If it gets too high, then don't use it. Angela says, you crack me up. Sorry for the sarcasm. It's my mother's fault. What can I say? But, you know, when people first hear me at part one, and by the way, David Kern, a physician from Hawaii, gave the last introduction to part one. And he gave a 2-hour presentation on me because he said he wished he would have known about me and understood me better before he would have jumped into part one. So he's trying to explain to people my thought process, my sarcasm, my passion for literature and science, and why we do what we do should be completely reversed based on the science and literature. But people don't quite understand that because they come to these courses with, yeah, but that's not the way I was taught or trained. I know, they come in with a confirmation bias. And the way that I try to help overcome that is through my sarcasm, which pokes fun at us, it pokes fun at me, it pokes fun at medical societies. And then people that used to think I was so sarcastic are now so very sarcastic themselves, which means I've created monsters, and I feel really good about that. So anyway, thanks for the thanks. Barbara asked, have you heard of iodine and armor shrinking fibroids and fibrocystic disease? Dr. Brownstein's hypothesis. Dr. Brownstein is the world's expert on iodine. He's written many books on it, gives lectures throughout the world on it. And in his experience, it protects against breast cancer, protects against fibrocyst, it shrinks fibroids. It does a multitude of different things, and I suggest you get his book and read it. So yes, indeed, iodine does help those things, and there are studies showing benefit. I do prescribe iodine. I prescribe iodine every day, and the brand name of the iodine that I use is Desiccated Thyroid. Did you get my drift? Benjamin says, hi, Neil. Hi, Ben. Awesome as usual, thank you. In our practice, we have noted significant and consistent improvement converting patients from synthroid to compounded T4 and T3. Yes. Do I have a ratio preference of T4 to T3? Yeah, my preference ratio is identical to that of Armor. 9 of T3, 38 of T4. That's in 1 grain of desiccated. For those people that cannot take desiccated or porcine for religious reasons, then you have to use a synthetic T4, T3, and I will use it in the same concentration as that in desiccated. What's the initial conversion? Is 0.1 to 1. Marlene, as always, enjoyed the lecture and your humor. You call that humor? But thank you for the thanks. And again, thank you for the accolades. I love to spend time with you. Chris says, thank you. Love your lectures. Thank you very much. I hope that you understand and enjoy the passion and enjoy the sarcasm. Because, if you sit and have gone through the literature for 20 years like I have, I spend my whole life reviewing articles. You should see my garage, my office, my bedroom, my bathroom, my storage unit, my den are filled with articles. And I try to pick, pertinent, important ones to use in the courses and in the webinars. The literature is just absolutely overwhelming that's out there. But what's overwhelming to me that we don't know and understand the literature, and there's no venue from any medical society to do so. I think the only venue is through the WorldLink courses. Thank you, Mary. Thank you, Dana. Laura asked, what do I do with a Hashimoto's patient who has a TSH of 10 and gets hyperthyroid symptoms even with the lowest dose of thyroid? Well, they have hypersensitivity to it. I would start with a very low dose, and if she can't tolerate a low dose, then you can't use it. I don't have any other suggestions. Hi, Chris. Is it safe for I can't read it. I think it says canaries. Is it safe for canaries to take thyroid? Yes. Optimize their free T3 levels and symptomatic improvement. When I first met Chris, he was not sarcastic. He is so sarcastic now, and I enjoy it. Hershey says side effects of Aricept and Amenda are confusion, hallucinations, anxiety, and aggression. All of the effects of Alzheimer's disease. Yeah, that's true. I know. We're using a drug to try to help improve symptoms, but causing perhaps other symptoms. I use drugs on occasion, not those drugs. I love metformin. There's other medicines that I do use. I'm an ER doc. Sure, I use drugs. I use medications. But for the most part, I try to optimize hormones, and we can help improve symptomatology and avoid the use of hormones. I mean, you can't stop the natural progression of aging, and that's the way God made us. But we can certainly help make people feel and function much better, and use our scientific literature to guide our therapies. Shelley says, is there a contraindication using iodine with Hashimoto's folks? No. I don't see any contraindication to using iodine. I've read that the iodine builds up the hydrogen peroxide in the thyroid, causing more damage. Gee, I wish Dr. Brownstein was here to answer that. There are some papers, literature, and feeling, particularly by endocrinologists, that iodine supplementation can be harmful. It might be in some circumstances. Supplementation of anything can be harmful in certain circumstances, but don't extrapolate that to it applies to everyone. So I don't see using iodine, it's in our food and in our vitamins, in patients with Hashimoto's, which is the most common cause of hypothyroidism, is harmful. So yeah, there may be some studies showing that excess iodine taken in high doses may have an adverse effect, but for the average everyday person, I do not find that to be the case. They would not hesitate in using iodine supplementation in these patients. Typically, we use iodoral, 25 milligrams twice a day, 50 total to load people, and then 25 to 50 on a daily basis. Hi, Dr. Birkin. I hope your book's doing well. Thank you for the thanks. Chris Holland said, carnies. Hershey says, how much calcium and what form do you recommend to prevent osteoporosis? I don't use calcium to treat osteoporosis. I could spend an hour discussing this. Some recent studies alluded to the fact that maybe the calcification in plaque is due to taking calcium. And some studies alluded to that. Other studies said, no, that's completely false. Some studies said, well, in people that took more calcium, they had a higher risk of plaque development, maybe. So now there's sort of a fear of using calcium. I don't fear it, but on the other hand, I would use calcium in a regular everyday supplement in a vitamin. I don't take additional excess calcium. We get plenty of calcium in our food, but please understand this analogy. It's not the calcium that's benefiting the bones when you take it. It's the hormone in your system, vitamin D, DHEA, testosterone, estradiol, that are carrier proteins to get the calcium into the bone. In every person that has osteoporosis, you measure their serum calcium levels, it's perfectly normal. What are you treating, the deficiency in calcium? There's no deficiency. The levels are perfectly normal. But what's lacking is the hormone or the bus, the carrier protein that carries the calcium into the bone. It's not the calcium. You can take calcium all day long. There's multitudes of studies showing that taking calcium by itself does not do anything. It does not help improve osteoporosis or decrease bone loss. Multitudes of studies show that taking hormones do improve it, significantly so. The only medicine that really increases bone density is estrogen in the form of estradiol. But everyone wants to give calcium. It's not the calcium that's a benefit. There's plenty of calcium in the muscle. There's plenty of calcium in the bone. There's plenty of calcium in the blood vessels. But what's lacking is the carrier protein that carries the calcium into the bone, if you get my drift. Ipraflavone is another molecule, another medication that can be used to carry calcium into the bone. It also increases osteoblasts and decreases osteoclastic breakdown. So there's a multitude of factors that affect calcium transport into and out of the bone. It's not the calcium. It's the transport bus. It's that mechanism that's important. So I hope I've answered your question. I don't specifically recommend any particular type of calcium. It's your choice. Pick whichever one you want. Calcium carbonate are the common ones, but I used to use calcium gluconate or any one of the proteins along with calcium. Another question is, a woman on desiccated thyroid gets pregnant. Should she stop it? So my doctor told me to stop it. OBGYNs typically will not know or understand thyroid. And as a result, they may tell the patient to stop it. When you stop it, they will gain more weight. They'll get gestational diabetes. They'll have significant issues. So no, I don't stop it. In fact, when you go through pregnancy, you increase thyroid binding globulin, which further lowers your free T3. So if a person is typically on 1 grain, probably through pregnancy, I may raise it to 2, maybe even more. But I let the patient review that with the physician and let the OBGYN manage it, because otherwise it'll be just confusing for the patient and very confusing for the doctor too. On the other hand, for those numerous patients that have miscarried and have stopped their progesterone and stopped the thyroid, they come back to me and say, okay, now what do I do? All right, take it. Don't tell your doctor. I take it all the way through. And if you want to see all those babies, I got pictures of them on the back wall of my office. People just don't quite understand the importance of thyroid for general health, but also through pregnancy too. So no, I don't stop it. Aaron Butcher, hi Aaron. So thank you for all you do. Thank you very much. 70% of my patients have free T3 levels of 6 to 10. That's way too high. And they lose weight. You shouldn't use thyroid for weight loss, Aaron. I advise you not to do that in the past, and you still can do it, still continue to do it. And they feel great. You should not use thyroid to feel great. The reason you use thyroid is to normalize TSH. I hope that you get my sarcastic drift. You know, it's interesting, you know, when you first started doing this, Aaron, you didn't realize it. But now when you do it, you know, now you're the expert on it, you'll see where they feel better. You'll see where they lose weight. And yes, there's free T3 levels of 6 to 10, which is very super physiologic. And other physicians will have a fit with that and have problems. So if these patients are going to involve another physician, I will not treat them. Sorry. I can't treat you if you're going to involve another physician in this, period. It's nice to have information that I'm doing the right thing for my patients. Making them feel good, making them lose weight, lowering the cholesterol is what we should all be doing. Keep doing the good job that you're doing, Aaron. Andrea says, what about the use of T3 early in the morning to improve cortisol production when you get up? Sure, you can do that. Are there some patients with fatigue using this method with success? Absolutely. That's what I recommend in the chronic fatigue lecture in part 2. Dr. Monoshito says, do you ever recommend desiccated thyroid BID? Yes, absolutely. I do. We look at all the therapy in the lectures in part 1 and part 2. Dr. Klein says the excess calcium is due to vitamin D3 without vitamin K2 and MK7. If you believe that, that's fine, which carries calcium into the bone and into the teeth. Most physicians have no idea about this. Vitamin K2 has no known toxicity levels. The only problem with vitamin K2 is the cost. And that's why the amount that you get is so small, because it's so expensive. And the amount that you get in the supplements is so small that it's barely beneficial. Look at the studies. The symptoms of high vitamin D3 are the same as deficiency of K2. Yes, we review that in the part 3 lecture on vitamin D. Chris Newman says, LOL. Thank you very much. Hope it's fun. Maureen says, hi. Thank you, Maureen. Hi back. Well, I think we finally come to an end. Phew. Thank you for not asking any more questions. The next webinar will address all the issues, problems, complications of misinterpreting thyroid studies. I will also look at a superb article, and I think it's probably the best article that addresses the medical legal issues of thyroid and the AACE guidelines and the medical board's stance on thyroid. It completely trashes their guidelines, the American Thyroid Association recommendations based on literature and science. So look forward to that. Have a great month. Talk with you next month. Thank you, Mary and Dana.
Thank you, Dr. Rosier. I hope our listeners enjoyed it as much as I did. Our next webinar will be on Wednesday, March 14th with Ilona Bleeman, entitled Clinical Diagnosis and Treatment Plans for Complex BHRT Female Patients. Dr. Rosier's topic will be on April 11th with a continuation of the thyroid. Thank you again, Dr. Rosier, and everyone who joined us today. Have a wonderful rest of your day.